Hey there, welcome everybody to the Ataxia Global Young Investigator Initiative webinar series. The Ataxia Global Initiative is hosting this webinar series for young investigators in the ataxia field to introduce to important aspects of various research topics. In the current and first webinar series, each AGI Working Group will present an introduction into their topic. The first half of the presentation will provide an overview of the utility of MRI in the diagnostic setting and clinical care of ataxias, and the second half will summarize the main MR modalities used in ataxia research and the type of information they provide. Between both parts, there will be a 5-minute break for questions regarding to the first part of the webinar, but there will be a bit more time at the end for discussion after the second part. Many thanks for being here today, and so please enjoy the talks. And with this, I would like to hand over to Gülin.
Actually, Sirio will start.
Oh, sorry, you changed? Yeah. Sorry. Then to Sirio.
Thank you. And now I'm going to share my screen. Now you should be able to see my screen, hopefully. And if so, well, thank you so much for the kind introduction, Jennifer and Heike. Thank you for organizing this webinar. And thank you, AGI, for the invitation, having us today, having a presentation of our working group and the related activities. So this is the outline of the presentation I'm going to give you in the next 20 minutes. So we're going to have a brief introductory part of the anatomy on what is possible to see with the conventional MRI of the anatomy of the cerebellum and in the infratentorial compartment. Then a very brief overview on the conventional MRI sequences that are used in clinical routine when evaluating patients with ataxias, and then a very fast overview on the main conventional MRI findings in the most prevalent hereditary ataxias. And before starting, we're going to have a couple of questions just to understand the background of you people hearing this webinar today. So if you can please answer these questions you see now. So just to have a very brief idea of who you are.
I will give the participants a few more seconds to answer this question. Almost half have answered now, and I can already see what the results are. So just a few more seconds, and then I think we have a nice overview of our audience today.
Okay, so from what I can see, mostly neurologists, some neurologists, which is cool, some people with expertise in MRI, not physician, and other people without an expertise in MRI. And most of the people are very scattered, actually. Some people still in residency and a PhD student, enrolled in a PhD student, and some people with more than 5 years at least. Okay, so some of this information might be new to you, some other might be redundant, so I apologize for that. I'll go through this very, very fast, and we'll start from the anatomy, what you can see using conventional MRI in terms of anatomy. So as you know, the brain is divided in a supratentorial and a lower infratentorial part, the so-called cerebrum, the supratentorial and the cerebellum and brainstem are part of the infratentorial compartment. These are divided by the tentorium, which is a tiny, thin meningeal sheet, and so divide these two parts. And of course, it is possible to study with MRI both the supratentorial and the infratentorial compartment, as you can see. The infratentorial compartment actually follows an unwritten rule of the number 3. So the cerebellum is possible to be divided in 3 parts, like the vermis, which is a median part. You can see here. I hope you can see my mouse here, and 2 hemispheres, so right and left, as well as from an anatomical standpoint in 3 lobes, an anterior lobe and a posterior lobe, and a floccular nodular one, which are respectively here depicted in red, green, and blue. And of course, it is possible to see this part of the anatomy using MRI. As you can see from in the images over there, the vermis in purple here, which is median, and the two cerebellar lobes on the left and right. In orange, the anterior lobe, and then going bottom to bottom in yellow, the posterior lobe, while you can see here in light purple, the floccular nodular lobe. So it's actually possible to study with conventional sequences the normal anatomy of the cerebellum. The cerebellum is connected to the brainstem with three major tracts of white matter. Again, number 3, the so-called cerebellar peduncles, which are from the top to bottom, the superior, the middle, and inferior. You can see in the scheme here, blue, red, and green. And yet again, it's possible to see these three structures using conventional MRI. You can see the superior peduncle in blue here on the right, the middle cerebellar peduncle in red, which is the thickest of the three, and the inferior cerebellar peduncle here in green. This is an image in sagittal, on the sagittal plane, is just to show you that it's possible, of course, to see the midbrain, the pons, and the medulla oblongata, which altogether compose the brainstem. And on a sagittal, pure sagittal acquisition and plane, you can see the vermis, which is median, here, all this part over here. While if you go through the plane in a parasagittal view, you can see the anterior and the posterior lobe, which are divided by the primary fissure here. The deep gray matter nuclei of the cerebellum are actually 3. Actually, they are 4, but one of these, the interposed nucleus, is composed by the emboliform and lobes, and they are stick together. So we can say there are 3 major deep gray matter nuclei. Actually, of these 3, with conventional MRI, you can only see the biggest one, which is the most represented one, which is the dentate nucleus. You can see this structure here as a thin hypoantenna, so slightly darker than other sequences, the other structures. Here you can see bilateral dentate nucleus. Okay, so again, this was a very, very fast overview of the anatomy. Just to be sure that everything is clear, this is a very fast question. So which one of these structure is possible to see with conventional MRI and which one, of course, is not? So please select the one is not possible to see with conventional MRI.
So far, people are paying very well attention, I think, Sirio. At least I hope that the answer that most of you chose is right. Let's see.
I hope Okay, so luckily all of you, mostly all of you, the famous 5% of P005 choose the dentate nuclei. All the other people choose correctly, which is the locus ceruleus, which is a very thin structure of deep gray matter, which is not possible to be evaluated using conventional MRI. Okay, so going through the second part of the presentation is going to be which sequences do actually we use to do clinical evaluation of patients. There are a lot of sequences that you can use in clinical care when studying patients with cerebellar ataxias. Of course, you cannot go through all of these due to time, and I will not go through all of these due to time. In a very brief way of summarizing, you can say that using conventional MRI, you usually acquire T1 weighted images, T2 weighted images, diffusion, and susceptibility weighted images. Due to time constraint, I will not go through DY and SWI, and I will just give you some information about T1 and T2 sequences. Just a brief note before going through these two kind of sequences. You must remember that ideally you should acquire all sequences, all planes, for a complete evaluation of the entire brain, and in specific, of course, of the cerebellum. So starting with the T1 weighted images, this is a typical T1 weighted images. You can recognize it from its contrast. There is this rule that we teach young neuroradiologists to understand and see which kind of images we are working on. And the T1 weighted images follow the rules of the gray is gray and white is white, which means that gray matter, so the cortex has a grayer, so kind of hypo-intense signal compared to the white matter, which appears brighter, so it appears white. So the gray matter is gray and the white matter is white. As I told you before, you ideally want to acquire 3 planes because you want to evaluate all the structures that I told you before. You should evaluate on all the planes. So you have an axial and a coronal and a sagittal T1 weighted. The problem with the conventional sequence like Spineco T1 is that these are slightly time consuming in terms of each one of these usually takes, it depends on the scanner, of course, but something like 4 to 5 minutes to acquire each one of these. So at least you're going to spend 12 minutes to acquire 3 planes in T1 weighted sequences. This is not ideal for patients for several reasons. And most importantly, some of these sequences show some artifacts, especially at the level of the cerebellum. As you can see in this image here, you have these artifacts at the level of the fourth ventricle due to fluctuation in the fourth ventricle that provide you these kind of artifacts here. You can see these blurry images at the level of the cerebellum, which is even more highlighted when you do contrast enhanced gadolinium. Let's take this example, which is not an hereditary ataxia, another disease. You have 2 foci of possible enhancement you can see in the pons and the middle cerebellar peduncles. Which one of these is true? You can actually solve this issue by acquiring a different plane. Of course, you can see that the pontine one, so the most anterior one, is actually a real enhancement. You can see in the green arrow, while the most posterior one at the level of the artifacts that I showed you before, it happens, actually is not a real enhancement. So how do we overcome this problem of the artifacts and the time consumption doing Spineco T1 weighted? We do actually acquire gradient eco T1 weighted images. You see in the lower row in this image here in this slide, this is a T1 weighted because the gray and the white is white. It's a slightly different contrast from the typical Spineco T1 weighted. It's actually kind of better because you can see better the cortex, and Gülin probably going to tell you later how you want to use these images for research purposes also. But the most important thing is you can see there are no artifacts in this kind of sequences at the level of the cerebellum, here at the level you see of the fourth ventricle. And this sequence is just one sequence that you can reformat on different planes. So basically you can acquire just one single sequence in around 4 to 5 minutes, it depends on your scanner, and then you could do multiplanar reconstruction to reconstruct all the planes and evaluate so the cerebellum and the rest of the brain on the other planes. So this is a very good opportunity to avoid time consumption. Furthermore, you can do different reconstruction, like this one is a para-axial reconstruction. And just to show you that on the left, of course, you have a pathological sample, and you can reformat the brain of the single subject to resemble the one that you can have in the pathology. So you see that the vermis is very, very clearly evaluated, as well as the remaining part of the brain. So it's a very good and feasible sequence, the T1 gradient. Moving to the T2 weighted images, this is a typical T2 weighted image. You can see that the contrast is actually completely opposite from the T1. It follows a different rule, which is the gray is white and the white is gray. Which means the cortical is slightly hyperintense compared to white matter, which is the opposite of T1 weighted. Why do we acquire T2 weighted? Not just because it goes with our brain of doing something like that, because this is, I'll show you an example. This is one a T1 weighted images I showed you before. This is the T2 weighted images. And you can see that using T2, you can more easily detect the presence of white matter abnormalities. Like in this case, you can see in the dots, the presence of white matter hyperintensities, which are slightly unseen on the T1s, because the T2 weighted images are more sensitive to the detection of white matter abnormalities. You can also decide if you want to subtract, so take to 0 the signal of the CSF, which you can see here is in the image on the right is black, is hypointense. And why you want to do that? Because in doing so, you all can also enhance even more the pathological characteristics of the tissues in case of disease. As you can see here in the images, they are slightly even better seen, these lesions. This is particularly true for specific lesions, such as the juxtacortical areas, so lesions nearby the cortical areas, as well as thin lesions at the level of the ventricles, and very thin lesions at the level of deep white matter. So ideally, again, you want to acquire all the sequences on all the planes. So basically, you want to do T2 weighted on 3 planes and FLAIR on 3 planes. Now, the problem, since I said to you that FLAIR is more sensitive to detection of pathology compared to turbo Spineco T2 weighted, So the real question is, why do we acquire normal standard T2? And the answer actually is yes, because FLAIR sequences, which are very good to detect white matter lesions compared to standard T2, actually in the infratemporal compartment show some presence of artifacts mainly related to not suppressed liquor CSF signal, as you can see at the level here of the prepontine cisterns in the purple arrow, here also highlighted at the level of this image on the right, as well as in the fourth ventricle, where you can see this false image, positive image, like there is something in the fourth ventricle, which actually is not, that's an artifact flow. Not only artifact flows, but also artifacts due to not suppression of CSF signal. As you can see here in red, this is a FLAIR image, of course. You see these thin, hyper-intense stripes at the level of the cerebellar folii, which can resemble the presence of subarachnoid hemorrhage at the level of cerebellum, but actually they are not. These are simply not suppressed CSF signal at the level of the folia. So it's something that happens on FLAIR, and it's something you want to take in consideration when evaluating the patients, because you can do something wrong, like saying that there is blood where there is not. So please consider the idea that although FLAIR sequences are the best sequence to detect lesions, they are not the best sequences to do that at the level of the cerebellum due to flow artifacts and lack of suppressed signal. Okay, so this is the fourth and last question from my part, and then we go through the main conventional findings. So which one of these sentences is wrong? Please vote.
We'll give the audience some time to evaluate your options, Sirio, and see if they score as well as last time. We're almost at 50% who have voted, so I always think that's a nice threshold. So let's see.
Okay, and 70%, I really appreciate that. That's cool. Yes, of course, as I told you, FLAIR T2 weighted, although is the best sequence to detect white matter abnormalities, so signal changes due to pathology, they are not the best option to do at the level of the cerebellum or infratemporal compartment. You want to evaluate normal T2 weighted images, not FLAIR suppressed, because they are kind of better at the level of the infratemporal compartment. Okay. Last but not least, of course, the conventional MRI findings in the hereditary ataxias. Actually, what you want to do, or you would like that your neuroradiologist has to do, is to have a checklist. So when you evaluate images, you want to evaluate, of course, the pattern of atrophy, not just simply say cerebellar atrophy. You can divide, although even through qualitative evaluations, a pattern of atrophy with the pure cerebellar atrophy or the involvement of the brainstem. But you don't stop there. You want to say if there is a mainly vermian or a mainly hemispheric or a diffuse cerebellar pathway, cerebellar atrophy. And when you talk about the involvement of the brainstem, if there is involvement of the pons rather than the entire brainstem with the midbrain and the medulla oblongata. After evaluating the pattern of atrophy, of course, you want to see if there are infratemporal signal changes. And then, of course, you don't have to forget the remaining part of the brain, which is the supratentorial. So the cerebrum, if there is a pattern of atrophy or signal changes at the level of the supratentorial compartment. I think that I'm not the best person to say that there are a lot of ataxias in the world. So just to remember that, of course, we are not going through all of these. I will start with the most atypical one in terms of conventional MRI, which is free-direct ataxia. Why it is the most unconventional one? Because it is a condition in which the cerebellum is basically spared. As you can see in this image, in the upper row is a patient, in the lower row is an healthy control. Basically, there are no difference in terms of cerebellar volumes, in terms of midbrain, in terms of pons. So they are actually the same because the cerebellum looks normal in Friedreich ataxia at conventional imaging. It happens to have the presence of cerebellar atrophy with some medulla oblongata atrophy in a very last part of the disease when it comes very much manifest. But in most of the phases of the disease, the cerebellum looks normal in Friedreich ataxia. Unfortunately, you don't usually work with these cases. What you will have and evaluate are patterns like these, in which you have a mild diffuse cerebellar atrophy, not that much pronounced, probably some involvement, as you can see in the patient upper row of the pons. Here at this level, it's a little bit atrophic compared to the normal one, or even more significant cases like these two patients in which there is a very much significant cerebellar atrophy. You can see all these folia, how they are enhanced compared to the normal appearance. Let's say, for example, you have two patients, one on the left, one on the right. What you can see here in these images is basically a significant cerebellar atrophy, global, so both Vermean and hemispheric. They look kind of the same, kind of hard to distinguish between these two. As I told you before, you have to evaluate different planes and you want to evaluate different structures. When you do a sagittal images, you can see that the patient on the left has a almost preserved pontine volume, while the patient on the right has a significant pontine atrophy. Why this is important? Because evaluating and taking in combination these two patterns can help you differentiate between these two conditions, which are respectively spinocerebellar ataxia type 1 and type 2. Indeed, starting from spinocerebellar type 2, it is characterized, as you saw, by a significant presence, the presence of a significant cerebellar diffuse atrophy as well as pontine. In some cases, a hot crossband sign, which is the T2 weighted hyperintensity of the at the level of the pons, has been reported. You want to take this in consideration. We will see why later. While in type 1 patients, there is a similar pattern of olipontocerebellar atrophy, although, as I told you before, as I showed you before, the pattern of atrophy is slightly less severe, although being actually severe, but slightly less severe than SCA2 patients. Please notice that also in SCA1 patients, you have the presence of this hot crossband sign. We'll just go very fastly through the hot crossband sign because it has an historical importance. At least here in Italy, it has been firstly described by Mario Savoiardo, has been also taught to neuroradiologists as the Savoiardo sign, which is indeed the hot crossband sign. Has been reported for the first time is in MCA-C, type C, and it was supposed to be the pathognomonic sign of MRI for this condition. Actually, due to the increase in literature over time, you see now that mostly all the conditions in the world have a hot crossband sign. It goes from metabolic to inflammation to neurodegeneration, as well as you can see here in H, of course, hereditary ataxias. And indeed, as I showed you before, a hot crossband sign can be present in SCA1, SCA2, even slightly in some cases in SCA3 patients. So unfortunately, this sign cannot be used to differentiate between SCAs, has to be reported, but it's not a pathognomonic sign. Talking about SCA3, it actually has a pattern of atrophy which is way less severe compared to SCA1 and SCA2. As you can see, mostly Vermean atrophy due to enlargement of the fourth ventricle, but relative sparing of the other structure of the midbrain, of the brainstem. So the question now is, are there conditions in which MRI can be actually helpful? There are MRI signs that can be used in clinical routine. There are some, for example, RSAX patients typically show a very peculiar pattern of combination of atrophy, like you can see the upper Vermean, apparently selective upper Vermean atrophy, along with the upper cervical core spine atrophy. You can see here in the head, in white head. The presence, not always reported, but somehow typical characteristic of this slight hypointensity at the level of the pons, here by the black arrow, as well as I told you before, don't forget about the upper part of the brain, a pattern of parietal atrophy, as you can see by the enlargement of the sulci here on the right images. Not only RSAX, also other conditions like ataxia, in which there are other typical MRI findings, not at the level of the infratentorial compartment, actually, which again just as characterized by the presence of some degree of atrophy, mainly Vermian actually, but the presence at the level mostly of the supratentorial compartment of this T2 and gradient and SWI, if you use SWI, hypointensities, you can see here in the black arrows, which reflects the telangiectasia due to hemosiderin deposition. Another typical, let's say, pattern of imaging is the cerebrotendinous xanthomatosis, CTX, let's say, which is characterized by a variable degree of the cerebral and cerebellar atrophy, but most importantly, by the presence of these mixed mixed hypo and hyperintensity at the two images, at the level of cerebellum, which shows some T1 hyperintensity. Here you can see this line here, and hypointensity in SWI, which is a reflection of a complex phenomenon of vacuolization and classification, which is indeed very typical of CTX. And finally, one last, let's say, typical, so much typical finding that in some cases it has also been included in diagnostic criteria, and these are the in fragile associated tremor ataxia syndrome, FXTAS, in which two major MRI findings, which are namely the presence of these T2-weighted hyperintense lesions at the level of the MCPs bilateral, as well as the presence of the splenial lesion here at the level of the corpus callosum, have been included in the diagnostic criteria to achieve a diagnosis of FTXTS. So there is some room for MRI to do diagnosis. And so I will leave you with these take-home messages, which are basically, with the conventional MRI, you can actually see a lot of structures. You see most of the structures at the level of the infratentorial compartment, at least at the macroscopic level. Of course, you cannot see very much small nuclei, but you can see a lot of the big structures. When evaluating your images, please remember that 3D T1 weighted gradient echo sequences are way better than normal spin echo, so please do that for several reasons. And when evaluating T2 weighted images, please remember that although flare images are the best sequences to detect lesions, at the infratentorial compartment, they are prone to some artifacts, so please remember to evaluate at least the T2. My suggestion is to do the T2, evaluate the T2. Unfortunately, as you can see, written in small, there are no pathognomonic MRI signs, unfortunately. There are, nevertheless, the possibility to evaluate a pattern, the presence of different MRI conventional signs that, taken together along with a good clinical evaluation, can allow you to provide good diagnostic information to the patient and the clinician. And basically that's it. So thank you so much.
Thank you, Sirio. There are currently 2 questions, so maybe we could go through these shortly. One is from Christine Escamilla. Does volume-based structural coherence and/or pontocerebellar atrophy predict FRDA disease progression and advanced ataxia?
So using conventional MRI, unfortunately, the problem of using conventional MRI is that you do mostly a qualitative evaluation. You cannot do a quantitative evaluation of this. Probably Gülin is going to talk about the quantitative evaluation later, and going to say that probably you can predict using quantitative measurement. For sure, unfortunately, in Friedreich ataxia, in most of the cases, when you do evaluations, you are not able to predict anything. You just have to report the absence of any kind of specific finding. I'm sorry.
Gülin, did you want to
I
add
know that was not
there?
the answer you wanted, but
No, I think Sirio explained it clearly. Yeah.
And there was one other question about SCA14 MRI changes. Can you say anything about that?
Oh, I don't have the image, like the question here. So
Yeah,
the question, what was
the
that?
question was, will you go over SCA14 MRI changes? But I thought maybe that it is something you can say a bit about.
Okay. So basically, which is the pattern of atrophy in SCA14? I guess that's the question. So, okay, perfect. So the pattern is a kind of heterogeneous one, mostly related to the presence of cerebellar atrophy with some pontine atrophy. The cerebellar atrophy is mostly Vermian, actually. They reported some disruptive cases of widespread changes. So it's mostly Vermian with some hemispheric changes and pontine atrophy.
All right, thank you. That's all the questions for now. If there are more questions, you can still put them in the chat or in the Q&A. But for now, we'll give the floor to Gülin, who will do the second part of this webinar.
All right, so I just shared my screen and let me put it in presentation mode. So you can all see the slides and hear me well?
Yes, perfect.
Okay, all right, so let's switch to research that is primarily quantitative as opposed to qualitative evaluations of MR images in the clinic. So at the end of this presentation, you guys will have an idea of utility of magnetic resonance imaging and spectroscopy for ataxia research. In particular, what types of pathology, what aspects of pathology can be monitored with MRI, MRS, and outline the most commonly used MR modalities to study ataxias. Before I start with the talk, I'd like to get an idea of the familiarity with the different techniques that we will be talking about. So do you use quantitative neuroimaging in your research? And if you do, which of these techniques? You can mark all that apply. Anne-Marie, if you can start the poll.
All right, answers are coming in very quickly. So we can give it a few more seconds. Maybe we even get to 100% response rate. No, doesn't look like it. We're stuck at 80, I think.
That's good enough. Let's take a look. All right, so there's a lot of experience actually in MR methods and using them in research. Okay, 30% is not using neuroimaging, 70% are, and primarily morphometric. That's what I would have expected. And then there are people who do diffusion and MR spectroscopy. Wow, 44% diffusion MRI, 37 MR spectroscopy. And then some with susceptibility weighted MRI got 30% of the votes. Okay, so I have a pretty good idea now. Thank you. All right, so the uses of MRI in research go in kind of two directions. One is about understanding and monitoring pathology, and of course, this has potential diagnostic and prognostic applications in the future in the clinic. And then the second one is clinical trial use and getting ready for clinical trials to utilize these MR methods in robust fashion. And I'm going to touch upon four areas: morphometric connectivity, function, and biochemistry measurements using MRI and quantitative measurements of these. And I'll try to cover these areas with examples from different types of ataxias, hereditary and sporadic, just a sampling. And bear in mind, this is a very limited view of what's out there. So let's start out with a very simple overview of the most commonly used MR modalities. This is a figure from a recent review paper that I wrote with doctors Ian Harding and Catherine Reeds, where we identified the most commonly used MR measures and displayed in this figure the some results for the most common ataxias in each of these groups. This is the Friedreich's, the most common recessively inherited ataxia. ACA3 is the most prevalent in the SCA group, dominantly inherited ataxias, and MSAC, multi-system atrophy, the cerebellar form, as the prevalent example of sporadic ataxias. So on the top row, I have some structural morphometric MR results, and these come from the conventional MR techniques, the T1, T2 type imaging data that Sirio already described, and we are specifically looking at the cerebellum and a flattened version of the gray matter of the cerebellar cortex. And already by looking at the color map, which displays the effect of the atrophied regions of interest, you can see these are disease specific. The involvement in Friedreich's ataxia here is the regional involvement is different from MSAC. For ACA3, we are looking at a region of interest analysis, whereas these are voxel based. That's why the maps look different, but just to give an idea of different patterns of involvement. Similarly, with diffusion MRI, that is based on the diffusion of the water molecules in the brain, and primarily this is applied to the white matter tracks, looking at the anisotropy of that diffusion and learning about axonal damage as well as myelin disruptions. And similarly, the pattern of involvement, you can already see there are some differences. The last one is MR spectroscopy, and that technique gives you concentrations of metabolites that are millimolar level or higher, the highly concentrated metabolites, that small molecules that give rise to an MR signal. And in all of these examples, you see changes. For example, this NAA, and total N-acetyl aspartate, this is considered a neuronal marker. Whenever you have neuronal dysfunction or loss, you see this peak go down, and you see that happens in all three diseases that we have example data from. In fact, that is the only change that is visible in Friedreich's ataxia. You go to SCA3, you have an elevated creatine that may indicate either gliosis or disruptions in energy metabolism. You go to MSAC, there's more severe involvement, and you have this other neurochemical myoinositol go up. It is typically considered gliotic marker. And these data were acquired from the cerebellar vermis. So we already saw there are different patterns of involvement between different ataxias, the hereditary versus sporadic and recessively dominantly inherited. But even within SCAs, for example, you can see genotype-specific atrophy patterns. And my example here is from an SCA study that included SCA 1, 3, and 6, came out in 2003, and showing in a longitudinal fashion the volume loss with baseline data and 2-year follow-up data. And you can see the clear differences. For example, look at the overall cerebellar atrophy, the extent of atrophy being most severe in SCA6 here, followed by SCA1 and SCA3. You look at the pons, SCA6, the pons in SCA6 is fairly not atrophied much. And the dotted lines here are the SCA-specific control groups. And longitudinally, perhaps surprisingly, you see that the longitudinal volume loss may be even in non-cerebellar and non-brainstem regions like the putamen and caudate data show. So very disease-specific atrophic pattern that you have access to. Then in the same study, the investigators looked at the sensitivity of change over time of clinical measures and these volumetric MR measures. And of the clinical scales that they have used, SARA, the scale for the assessment and rating of ataxia, by far the most widely validated and used ataxia scale. That was the most sensitive to change based on the effect sizes that are listed here. Effect size being mean annual percent change divided by the standard deviation of the annual percent change. When they compared that to the volumetric measures and their effect sizes, in each disease case, they saw that the volumetric measures effect sizes were higher than the SARA. Here, this is being 1.6, 1.5. This is the time standard deviation. And with the SARA effect size being 1.2. Same story in SCA3, and most strikingly, you see a difference in the effect size for SARA in SCA6 versus these three measures, the volumes, and their very high effect sizes. So indicating that these volumetric measures have higher sensitivity to change over time. Well, how about access to these changes at the different disease stages? Here I have a very nice example from a large study in SCA3, where they subdivided their cohort based on their time from ataxia onset. And they also had individuals who were not showing any ataxia signs and symptoms yet. This is the top group. And you can see the level of volume loss increases with the time from ataxia onset. But most interestingly, you also see some involvement at the brainstem, pons level, and even up to substantia nigra. There's some volume loss even before the onset of ataxia. But volumetric, morphometric changes are not the only aspects of pathology that you can obtain. You do diffusion MRI, and that technique gives you very nice information on microstructural changes and changes in the various tracts. And this example is from Friedreich's ataxia, where they did both volumetric MRI and diffusion MRI. And let's first look at the volumetric MRI results at the bottom here. And these are volumes where the volume was smaller in their Friedreich's ataxia cohort than the controls. And the differences are limited to the cerebellum. You can see in the white matter region, as well as the pons. It's more visible here. When you look at the diffusion metrics, this is fractional anisotropy. Anisotropy gets lost with microstructural damage. So, and this metric is mean diffusivity. The water molecules start diffusing faster, more likely in all sorts of directions. So you see both of those and other diffusivity metrics change also in the cerebrum. And these are changes that are independent from each other, showing you that this kind of diffusion information can provide a lot of added information over and above volume loss. Continuing in the microstructural abnormality path, this is an example from one of our co-hosts here, looking at sporadic ataxias, in which case the diagnostic uncertainty is great early on. MSAC has a lot of autonomic dysfunction, but that may not be present early on when the ataxic symptoms start to show up. And you want to know where these individuals, patients are going, because MSAC has a much more severe prognosis. So here, what they are showing is the microstructural abnormalities can actually very nicely distinguish MSAC from sporadic adult onset ataxia, which has a milder course. All the green regions that are highlighted in these images in the cerebellar white matter, as well as the pons, nicely, statistically significantly distinguish these two groups, which in the future may help with this diagnosis. So we don't always look at the global cerebellar changes, gray matter or white matter. We can even get down to cerebellar nuclei in with these more research applications and modalities. And here's an example from Dr. Dagmar Timman's group, where they looked at different imaging techniques that are iron sensitive. So FLAIR that you already heard of from Sirio T2 weighted SWI, R2 star, and quantitative susceptibility mapping. And they showed that QSM, this is a method to analyze the susceptibility weighted images that provides you very nice delineation of the dentate nucleus. You see the dentate nucleus also in the T2 weighted images and SWI, but actually quantifying the volume of it accurately, you need to overcome some of the blurring artifacts, for example, not artifacts, but the structure looking larger than it actually is in T2 weighted or T2 star weighted images, and you need this kind of delineation of the structure, and you can do that with these techniques. And this is an example in actually the same paper, same work, where they used a functional task, a finger moving task, to look at the functional changes, again, going beyond morphometric changes in SCA6, Friedreich's ataxia, and SCA3. And these results are mapped, shown on a cerebellum template, and you can see the type of activation that you get in healthy control participants and how different it is. I mean, you look at Friedreich's ataxia, for example, where the morphometry of the cerebellum is pretty intact. By looking at conventional images, you can't see a difference. There is no atrophy, but functionally, all that activation is lost. Very similar story in SCA3. And not even over the whole cerebellum and different lobules of the cerebellum, you can start doing this in the dentate nucleus. They are looking at functional activation with the same type of task that is lost specifically in different parts of the dentate nucleus. In controls, here you have both ventral and dorsal activation, whereas in SCA6 you only have some lower activation in dorsal parts of the dentate nucleus. So moving on to spectroscopy, and this is the technique that I have done the most. This is my expertise. And everything I'll show you will be single voxel spectroscopy, where you select a region of interest, collect data that look like this. So all these images that we've been looking at, they are water-based, water images, and depending on the environment of the water, you get different contrast. Here you suppress that water signal, so you can see these millimolar level metabolites, and each of these peaks correspond to a different neurochemical of interest. You do some mathematical modeling, mathematical fitting, and you get endogenous concentrations, estimates of concentrations of a list of highly concentrated metabolites, up to 20 of them. And my example here is from SCA1, and I'm showing spectra from individual subjects, one control participant and one participant with SCA1. And I already talked about this peak, the neuronal marker, N-acetyl aspartate, NAA. Just by looking at the data, you can see it is lower in the participant with SCA1 than the control. The putative glial marker, myoinositol, is higher. Creatine, in this case, is higher. in SCA1 relative to control. And very similar story, although the myonostal increase is much more visually apparent in the brainstem in this case. So let's look at some spine spectra. And this is my second question for the poll. One difference you can see is the quality of the spectrum. You have broader lines, there's very broad baseline, but you can still visually evaluate these spectra. Here's the N-acetyl aspartate, here's the myonostal that we were talking about. And between these three spectra, there are two of them that were collected from participants with Friedreich's ataxia. By looking at the data, can you tell which ones? Anna-Marie, if you can bring up the poll. And you'll need to move the poll away to look at the data and then select which one. Which ones? A, B, or C?
Let's leave it a little bit longer. We have 12 answers so far of our 34 participants.
Okay.
So
is it 1 or 2 or 3? 1 and 3.
I would like to say there are no bad answers, but of course there are.
In this case, there's one right answer, yeah. But just think about the neuronal marker I was talking about, the glial marker, and pattern, the ratios of the different peaks to each other.
Right, let's see how our audience did.
All right. Almost 80% of you picked the right answer. Let's go to the next slide. Okay. So yeah, you probably noticed the NAA peak relative to the other ones is lower in these two cases, and the myonostal relative to choline creatine is higher. The NAA myonostal ratio is quite different. And these are, as I said, not great looking spectra, and many of you have not done spectroscopy before, but on an individual subject basis, you can see the differences. Okay, continuing on the NA over myonostal story, this is from one of our studies where we looked at neurochemical changes in SCA 1, 2, 3, and 6, the most common SCAs, polyglutamine SCAs. And I'm showing you sample data from the cerebellar white matter, and relative to a control participant, you can see just by looking at the data the differences in the patterns if you carefully investigate the data visually. And then when you do the quantification and plot the data, you see very clear difference of NA over myonostal for all SCAs relative to the controls. And in this study, we also had some individuals at the pre-manifest stage, people who had SARA scores lower than 3, no signs of ataxia yet. And those are the individuals whose data are marked with the circle here. And most of them, 6 out of 9, were actually grouped with the symptomatic individuals. And we found when we estimated their time to onset based on their CAG repeat length, those were the individuals who were 10 years from onset based on an estimate, who were already showing this neurochemical pattern that the symptomatic individuals were showing. So I have only few slides to cover the topic of clinical trial readiness, and these are data from our other co-host Dr. Heike Jacobi, where they estimated the sample size that would be needed in clinical trials when the SARA scale is used as the outcome measure. And this is as a function of the effect size and the number of individuals who would be needed per group in a 2-arm trial. And you can see, for example, in SCA1 with a power of 80 or 90, you need hundreds of individuals, even for like a 30, 40% effect size. So these trials are difficult to execute if you need this many individuals. And these are data essentially confirming the same kind of conclusion based on a US cohort. And the goal is to supplement these clinical measurements with the MR measures to possibly reduce these sample sizes for clinical trials that would be needed in the future. Just a display of the potential utility of these MR biomarkers in these clinical trials from the same review. You can, for example, use them for subject stratification at enrollment. Those people who are already showing differences at the time of enrollment could be the ones enrolled in the trial. Or, of course, you can utilize them to monitor the effects of potential therapies. This is just to give you the idea that the validation of these different MR modalities, MR metrics for different types of ataxias is at very different stages in the pipeline. You start out with biomarker discovery, potential markers that may mark X or Y in the pathology. Then they need to be validated for reproducibility, for sensitivity to change, sensitivity to disease onset, etc. And then they need to be validated clinically in large cohorts in multi-site settings. And these are the different modalities, and these are roughly displaying where this validation effort is in each of these different types of ataxias. So there's a lot more work to do for most of them. And then one final example for potential clinical trial utility, I came across this paper, which I thought was very cool. It's about potential novel MR biomarker in FX tags, the X-linked ataxia, fragile X-associated tremor ataxia syndrome. And here they did a lot of T1, T2 image quantification, but they came up with this one metric, very simple metric, MCP width, that's shown on this image here. And they enrolled these participants, longitudinally followed them, and these are all pre-mutation carriers. But the question is, are they going to actually develop FX tags or not? And can we have an imaging marker to predict that? And over the time period of the study, 2 years, some of their participants converted to symptoms and others did not. And they looked back, and this MCP width was already narrower in the converters as opposed to non-converters. And I thought this was pretty cool. And this is my last slide, acknowledgements, to acknowledge our working group, especially my co-leads, Drs. Ian Harding, Sirio, who you already met, and Dr. Pierre-Gilles Henry, but also all of the other very active participants like Jennifer, Dr. Christoph Langlet, Andreas Deistung, Dagmar Timman, and others. So I'm open to any questions, and let me stop sharing. Okay, I see a lot of chat activity. I wasn't seeing that. Anne-Marie, do you want to go through them?
Oh, yes. I mean, I believe there have been a lot of information exchanges between people, so that's been going well. We have a question for you
Good.
in the Q&A. The question starts with how, but maybe the first question is, could spectroscopy help in the differential diagnosis between neurodegenerative or acquired ataxia, and then how?
I would think yes. I haven't done a study to specifically determine that ability, or I'm not aware of other studies, but degeneration leads to very specific changes, like the NAA that we discussed, the gliosis marker, the myoinositol increasing, and I would imagine that non-degenerative acquired ataxias may not affect the same neurochemicals. We have some data from animal models, a longitudinal study, the first longitudinal mouse model study that I have done in my lab in SCA1. We identified two sets of neurochemicals. We did MRS histopathological correlations. One set of neurochemicals like the NAA, myoinositol, glutamate, they correlated really well with the progressive neurodegeneration as defined by histopathological, quantitative histopathology. Another set of metabolites like glutamine, taurine, and there were a couple of others that were abnormal only at the very earliest stages, and they did not correlate with the degenerative changes. So the answer is yes, but we haven't done that yet. We should look into it.
I don't see any more questions. I don't know. Jennifer, Heike, do you have anything to add?
Yeah, I would have a question, but I cannot use, as a co-host, I'm not allowed to use the Q&A, so I have to orally questions. So, at least in our hospital, in the clinical routine, MRIs is not routinely used. So do you envision any steps that can facilitate the use of MRS more routinely, maybe even more in a clinical setting and not that much in a research setting?
Yes, that's a great question. MRS in the clinic is primarily used for like brain tumors, in brain cancers. There are sites, again, specialized sites that use spectroscopy to even make clinical decisions. In other areas, in neurodegeneration, it is more in the research domain. I think one big problem is that the clinical, commercially available spectroscopy packages are not very well optimized. So if you have very major changes, like NAA goes to half of its normal value, or myoinositol shots up, or you lose creatine altogether in an inborn error of metabolism, those you can see even with the commercial non-optimized methods. If you need to see more subtle differences, the quality of the data becomes very important. We've done consensus efforts. There are some papers out there providing guidelines both to users and the industry to make these more advanced spectroscopic methods more widely available. We share our methods, the in-house developed methods, with any site that's interested, but of course it's a hurdle to use non-commercial methods for a lot of clinical sites, but there is work going towards that.
A short question.
Yeah, I think it's past 10 there. It's pretty late, especially for those of you who are joining from in Europe. Everyone must be tired.
Well, we're not tired enough to not ask more questions. Is there any advantage or difference using single or multivoxel MRS for ataxias?
So the big advantage of single voxel is you optimize everything in that region of interest. You shim your volume, you can get very nice narrow line widths, and if that's the region that you really want to find out, that's the ideal region. But of course, it's not 3D. You're losing a lot of information from outside the volume of interest. So it depends on the application. Now we have some new methods that reach the quality of the single voxel spectra over at least 2D slices. Again, in-house developed methods, that are so far not applied in the cerebellum, but at least in the cerebrum, and we are about to start using them in a multi-site study. But again, if the changes are very dramatic, there's a big advantage of using 2D or 3D methods, as long as the broader lines don't bother you and you can see the NAA decline and mannose-stole increase. So it depends on the question and application.
I think that's also a main take-home message, that a lot depends on your question and application. So I think we leave it at that. Thank you very much, Gülin. Thank you, Sirio, and Jennifer and Heike for organizing and introducing our speakers. If you leave the webinar, you will go to an after webinar survey that we would very much like you to fill out to improve our following webinars. And if you could just comment with your country and profession in the last question, because I forgot to add that because it's so late here in Europe. And with that, I would like to thank you all and hopefully see you next time.